The last session, Dr. Jorge Neira from Argentina is going to speak about challenges and dilemmas in the ICU trauma patient. Bienvenido otra vez. Gracias. Las diapositivas, por favor.
Bueno, muchas gracias nuevamente. Imagino que estarán cansados.
Thank you very much once again. I imagine that you're tired. Thanks to David. It has been an honor for us to be present here talking about our experience and the first title of the presentation of challenges and dilemmas in the ICU trauma patient. I have been for 40 years working in the ICU, so we could have another international conference just to speak about the challenges and dilemmas. That's why I decided to take only the aspect of the severe closed head injury in the ICU of a public hospital, the hospital that is serving the people that are not covered by the public insurance. Over the last 2 months, we have seen an increasing number of standards of care like the hypothermia, the functional evolution, and the ratio of the Glasgow score for the assessment of risk in patients with trauma injuries, the monitoring of the ICP, and especially the analysis in the use, for example, of the progesterone, like what Sandro Risoli mentioned about the need to treat patients with diabetic discharge. That is so important. If we need to use multimodal monitoring in patients with head injury, if we need to interfere with the specific drugs in the case of cranial pressure. And this last paper has some particular feature. It was submitted by Randy Chesel in 2013. This paper was the first that compared patients with cranial traumatism, and it was followed up with ICP monitoring versus the use of CAT scan, because it was done in countries with limitation in the use of intracranial pressure systematically, including Bolivia, Ecuador, and some other countries in Latin America. In fact, this paper, headed by Randall Chestnut, has included some Bolivian, Ecuadorian, Argentinian people. This paper proved that if we compare the evolution of patients with ICP monitoring versus CAT scan with the clinical assessment, the mortality at 6 months was the same, 39 versus 41%. The functional recovery was 56 versus 53, although obviously there were some ethical consideration and some methodological issues because of the misbalanced groups. That's why with this database that we have, we decided to review the information on neurotrauma in an Argentinian public hospital. We researched the severe head injury in a local trauma registry, the ICU admission, and two important elements like the ICP monitoring and the outcome assessment with the mortality and the GOS, and some future directions based on the outcome. Yesterday, I showed that 10% of the total deaths due to trauma, that the proportion of the age groups is the classical, as it is present in every developed and developing country with a higher frequency between 5 and 44 years of age, and this is compared to the evolution of the mortality of patients with different cardiovascular diseases in red or the neoplasms in blue. You can clearly see that the age average is much lower in the trauma population. I already showed the trauma registry yesterday that is in the web. We have a work methodology and a trained team in every location and hospital. We have codified according to what we saw yesterday. An interesting thing is that when we began with the registry 6 years ago, since it was the first time that we systematized the assessment of the severity of the injury, we began with the AIS 85 that is over 30 years old, and it was very easy because it had only two entries that were easily performed and identified. As we move on with the registry, now we have the 2005 version with the anno date of 2008, and we're using the TRIS methodology for the AIS and for the ISS, and we also use the Bartel and the US for the patient assessment. All of those patients are encrypted when entering the database, so we don't know the names of the patients, only what they have. In particular, this is the sequence. Let me add something that I skipped yesterday. In blue, we have the two pre-hospital systems that where we have a registry that is computerized, and it is geo-reference. So that geo-referencing makes possible to know information like the time of the ambulance, the type of traumatism, the hospital, the time of the day, the injury, and it is an important information, especially taking into consideration what Andres said about the need of a pre-hospital standardization of the trauma patients. In total, in the hospital, we have 20,000 patients. I just checked the database, and we have 22,200. That's how they became accumulated on the charts on the left progressively since the year 2010 to date. That's why in 2016 it is lower, because we closed in April for this presentation the prevalence of the male gender over the female gender, and it is very interesting in the chart below because you see the age ranges, and if you look at the dotted line in black, when they get to 35, 44, it goes on. That called our attention because many years ago, before we had the National Trauma Data Bank, we had the major trauma study developed by Howard Champion. The cut value for the patient in terms of the severity by age was 54 years, and it called the attention that 30 years later, in a database in a different country, we have the same cut value of 54 years of age. The frequency of trauma patients with head injury in the chart in the top, you see in dark blue the severity according to AS from 1 to 6. 31% of those patients had a head injury, and as we notice below, 31% had a severe head trauma. Of the 19,000 analyzed, 34,000 had injuries, and of those, 31% in the head. So we explore the database looking for the AS3 plus with or without injuries in other regions with an AS2 or more without affecting the consciousness, with a Glasgow equal or higher than 8, and patients over 15 years of age. The pediatric population was not included in the study. In total, 1,600 patients with trauma injury, with 249 injuries, 2 injuries by patient, and the isolated tech was 59%. So 60% of patients had an isolated tech. When you analyze the mortality between the isolated tech and the HI with other injuries. We have 22.9% in one case and 26.5% in the other case. That was not significantly different. If you look at the number of injuries, not the severity, obviously the mortality is related to a higher number of injuries. In the chart, you see that mortality is 14% with one head injury, and with 5 or 6, it goes over 50%, as you can clearly see on the chart below. In the case of head injury that is severe with a Glasgow equal or lower than 8, those were the ones that were mostly associated with a higher proportion of 60%. If you analyze the associated head with injuries, here it depends on the mortality and the number of injuries associated, but not with the same feature than when we see the trauma in the head when it is a direct injury. This is more horizontal, and eventually it becomes important when we have more than 6 injuries. In summary, the group had 85% of male gender, the age 38 female, 28 male, with an average of 29. The total mortality 24%, no significant difference between female and male. The age in survivors 28 and non-survivors 31. The hospital length of stay in survivors 6 days, and in the non-survivors 1 day. This is something that we're going to highlight because a large number of patients died in the first hours. What was the mechanism of injury that was most common? When we talk about an isolated head injury, the most frequent mechanism is the interpersonal assault. In the case of patients with head injury associated to other injuries, the most frequent cause, as we saw yesterday, was the motorcyclist, the motor crashes. So basically that is due to the fact that there was a low use of helmets. We're working on the use of helmet, though it is mandatory in a great part of the country. People don't wear it. If they want, they use it till they have a problem with the police and they have to wear it. But as you notice here in the chart below, the motorcyclists were the most common cause of injury in the combined head injury patients and in the pure patients. If you analyze the patients that were hospitalized in the ICU, 39% with an isolated tag, 52% with associated injuries, the same between survivors and non-survivors, 40 and 57%. But clearly, in the ICU length of stay, they had more severe lesions or injuries, and we have 13 or an ease of 16 and 35. That was clearly significant. The RTS, the physiological indicator, was lower. The TAS wasn't, and the GCS was clearly lower because it was 14 for the patients non-admitted to the ICU versus 7 in those admitted. This is interesting, the TAS as a non-present physiological marker, because we're going to see it related to the evolution of the patients. Here we have the percentage of monitoring of the ICP in the total patients. Of the 1,600, 28% had an ICP monitoring. 4 days of monitoring with a median between 2 and 7. And between the GCF points of 3 and 15, there is variability, focusing mostly the ICP monitoring in the 6, 7, and 8 GCS points. The severe cases did not have the ICP monitoring, and the less severe when had the monitoring, and when they changed the neuro worsening, that justified the use of the ICP monitoring. Here on the chart, you see the GCS from 3 to 15, and from 10 on, a percentage of around 50% had an ICP monitoring in both groups. Now, it is interesting to see to the left when it says hospital with the numbers. We put a number to the hospital instead of a name, because when we send the report, the hospital knows that it is its own information on how they compare to the others, but they don't know how the other hospitals are doing. And they have a number, and there is an important variability in the use of the ICP monitoring going from 81 to 0%. If you analyze the patient with the GCS lower than 8 when admitted and the ICP monitoring, practically 46% of the patient with an isolated HI and the 53% of the HI with all the injuries had an ICP monitoring, and there was a significant difference in the specific monitoring. Now, when we analyze all of the patients with HI, those with an ISS higher than 16, they had a significant higher mortality than those with a lower ISS than 16. So the more severe the case, the higher the mortality of that specific group in patients that otherwise would be considered as a major trauma. And patients with a GCS lower or equal than 8, patients with monitoring had a mortality that was significantly lower than those without monitoring, 47 in the case of the isolated HI versus 70 in those without monitoring, and with other injuries, 35% versus 60. So as I said, the most important topic was that an important percentage died within the first 24 hours, practically 90% due to the initial compromise. So the propension to monitoring was specifically related to the severity of the lesion or the injury, and the instability made impossible that in the patient. So if you analyze the number of CTs in every group, the number of those monitored was twice as much as those that were not monitored. This is a paper of Lim Berger, the group of the Harvard Medical Center, where they see that the aggressive treatment has a very prognosis than the non-aggressive. As I said yesterday, and it was said by Andres Rubiano, this has to do with a decompressive craniectomy. So the next point was to see how many patients have been performed on a decompressive craniectomy, and there is a clear relationship between those with a decompressive craniectomy and the ICP monitoring. If you analyze those with a Glasgow higher than 8 or lower than 8 with an ICP monitoring, it was clearly related to the LDC. In patients with a GCS equal or lower than 8, the LDC had a higher mortality in the group of monitoring that and those without monitoring. This probably should be reviewed in a larger group, because we think that maybe this higher mortality of the patient with craniectomy was related to the fact that they were more severe and they have a higher need of cranial pressure and a higher need than of the decompressive craniectomy. And this could be explained for the GCS at admission. In this case, the groups with a low result, like 1, 2, and 3, meant it was higher in patients with a decompressive craniectomy than in those that did not have it. The same for the group of patients with a Glasgow lower than 8 when admitted. That is the number of papers related to the debate of the use of LDC. We were talking with Andres that the Brain Trauma Foundation is addressing this topic to incorporate it in the new guidelines. So we're eager, waiting for those new guidelines. So in Latin America, we want to compare ourselves, our reality, with your reality. That is the reality of the developed countries. So our goal is to get together a Latin American group with this methodology to do a benchmarking with the major databases like the NTDB or the German Trauma Registry, because that is going to make possible to know what is happening with our resources if we compare it with the resources in the developed countries. Well, the mortality, in the case of the mortality causes in the associated and the related HI, the impact of the injury was related to the mortality of the patient, because the proportion you see that is quite low. So we have some doubts about that. So we're reviewing the database and some clinical records to see if because we have a 26% that is undetermined, so we would like to know more about that to see exactly how those causes are broken down. So this is something to do based on the registry. This allows us to get a model for the mortality, with the information available. If you took into consideration the score below 1.998 plus 0.051 of the NISS minus 0.901 plus 0.031, that is the age, we could have a prognosis of the risk of mortality associated to those patients. And this logistic regression model is quite proper. So it is quite proper in terms of the evolution of the curve. And finally, the patients that were more severe with a NIS higher or equal than 16, they had a NOE of 0.76. So there is a 20% higher when compared with the National Trauma Data Bank. For us, that lower adjusted survival was associated to the higher global severity injury group. If we analyze the Glasgow score, the GCS, in terms of the impact, as I said before, the arterial pressure did not have an impact here. There is a direct relationship between the RTS and the GCS, because the GCS is marking the evolution of the patient. We see a high dependency between the outcome and the physiological condition of patient admission. That has to do with the severity of the head injury. The decision to proceed with the ICP monitoring show heavily within the hospital. The GCS justify almost 100% of the variance associated to RTS. So the most important impact of the RTS was related to the GCS, and the patient with accelerated head injury presented higher mortality because of the higher severity injury group, and that mortality was 45% versus 35%. What we're doing to modify that, we began in March this year a program to improve quality. For that purpose, we invited the group of the WHO that is head by Dr. Charles Mock, and also we have Felipe Vega and Andres Rubiano in that group, precisely to begin working in the hospitals on those quality control methodologies. And the advantage is that we have 20,000 patients already in the database to begin working, specifically see what is required to improve in every hospital the management of the trauma patient. When Felipe Vega talked about the damage control laparotomy, and Andres Rubiano, when he talked about the cranial spine traumatism, I would think that the most important thing is in those patients is the management of the patient from the moment the patient is admitted in the hospital to the moment it is sent to the rehabilitation center. It is teamwork. And to the Latin American, this is more difficult than the developed countries. And even I don't want to mention the Argentinians. This is the group that took part of this. 70% in every group, including administrative staff, nurses, surgeons, clinicians, emergency staff, pediatrics, intensivists, because we need to work as a team. Now we're going to have a simulation. We have some experience in simulation because we trained 7,000 people with this program. And in fact, the non-technical skills are achieved with the simulation. That could make possible to have a better clinical record. We could have a major impact with a medical record, because up to now it has been only in black and white. So only in a few places we have a digital registry. That way we could have knowledge on the preventable death. We could also have analysis of findings, corrective actions, and also have a complete medical record and improved registry. We have developed a trauma motility committee in each hospital. We have a central trauma committee in the area of the hospital. And since March, we started the quality improvement program, not in the center, but in every hospital. So this is all what I wanted to say. Thank you for your patience. I look forward to seeing you in the future. Thank you very much.
questions?
Yes.
Hello. Talking about severe head trauma, talking about severe head trauma, does any of you have recommendations regarding medications to use during a rapid sequence intubation? So during intubation with an RSI, what drugs do you recommend?
No, nosotros en realidad la sistemática que tenemos depende de cada.
That we have depends on the hospital. Every hospital has its own systematic methodology, and we use what the hospital knows best and what they have available. So we're just working in the development of the National Quality Agency in Argentina to include some specific standards. But to date, every hospital decides the way to intubate according to what they have available, what is best for them.
Excellent.
Muchas gracias.